Assalamu alaikum. I am Dr. Dilip Kumar, and today our topic of discussion is the neoplasm of the large intestine. The tumors or the neoplasm of the large intestine are divided into benign and malignant tumors. The common benign tumors of the large intestine are the polyps, and the malignant tumors are mostly the adenocarcinoma. This is the colon, which is showing the cecum, ascending colon, transverse colon, splenic flexure, and the descending colon, sigmoid colon, and the rectum. The blood supply of the colon is mainly the superior mesenteric artery and the inferior mesenteric artery. The polyp is basically a grape-like protrusion of the tissue into the bowel lumen, which may be sessile, which is flat on the mucosal surface, or may having pedunculation. So if the polyp have a stalk, that is called the pedunculated polyp. The polyps may be epithelial or submucosal, and the polyps may be non-neoplastic or neoplastic polyps. The polyps can occur singly, synchronously in small numbers, or as part of the polyposis syndromes. The non-neoplastic polyps are hyperplastic polyps, juvenile polyps which occur in the children less than 5 years of age, and the Peutz-Jeghers syndrome. The Peutz-Jeghers syndrome, the polyps are mainly in the duodenum, small intestine, and the colon, and it is also associated with the orocutaneous melanin pigmentation. The neoplastic polyps having three varieties or three types. One is the tubular adenoma, the second is the villus adenoma, and the third one is the mixed. The villus adenomas mostly they are flat, and the tubular are that may be sessile and pedunculated. The neoplastic adenomas having malignant potential. The familial adenomatous polyposis, it is a generalized neoplastic disorder of the intestine, and mainly it affects the large intestine, but the stomach, duodenum, and small intestine are also affected by familial adenomatous polyposis. It is inherited as a Mendelian dominant disorder. Mostly the APC gene, which is present on the chromosome 5 on the short arm, and males and females are affected equally. The patient may be asymptomatic or having symptoms. The symptoms mostly are the loose stool, lower abdominal pain, weight loss, diarrhea, and passage of the blood and mucus. Polyps are usually visible on sigmoidoscopy by the age of 15 years, and the carcinoma of the large bowel occurs 10 to 20 years after the onset of the symptoms. So it takes 10 to 20 years to develop or the transformation into malignancy. Familial adenomatous polyposis is associated with benign and malignant lesions in other parts of the body, and the benign ones are the endocrine adenoma, osteomas, epidermoid cyst, hypertrophic retinal pigmentation, and the medulloblastoma. So if there is no genetic facilities available for the testing, so examination of the hypertrophic retinal pigmentation on eye examination we can diagnose, because the 50% of the familial adenomatous polyposis patients having hypertrophic retinal pigmentation. The malignant tumors or the malignancy can occur along with the adenomatous polyposis, the duodenal carcinoma, desmoid tumors, bile duct and pancreatic carcinomas, and carcinoma of the stomach. So if we diagnose the familial adenomatous polyposis, so we have to think of the malignant as well as the benign tumors in other parts of the body. So we have to diagnose by doing proper investigations. So for the treatment of the familial adenomatous polyposis, nowadays it is the restorative proctoclectomy with an ileoanal pouch anastomosis, because the treatment for the familial adenomatous polyposis or FAP is to prevent the conversion into malignancy, or if the patient having symptoms to prevent these symptoms, so we have to treat the FAP or familial adenomatous polyposis. So it is indicated especially in cases where with serious rectal involvement with polyps, who are likely to be poor at attending for follow-up, or with established cancer of the rectum or the sigmoid colon. But if there is involvement of the sigmoid and rectum and the whole of the colon, so there is a second option, the total proctoclectomy and the permanent end ileostomy. Colectomy with ileorectal anastomosis was practiced in the past as usual operation because it avoids an ileostomy in a young patient and avoids the complication of the sexual problems. So there is a screening program in the UK. They are mostly doing in 60 above in age patient, 60 to 69 years aged patient, and by doing screening they studied that their studies show that there is reduction in the morbidity and mortality 15 to 20%. So screening is done by doing fecal occult stool test, and if it found positive, so the sigmoidoscopy or the colonoscopy is performed in those patients, or we can do the screening by doing flexible sigmoidoscopy in spite of the fecal occult stool testing. So the carcinoma of the colon is the most common or the second most common gastrointestinal malignancy, and second most common cause of cancer death. 35,000 patients are diagnosed every year in the UK, and age group is 60 to 70 years of age. But if the tumor or the malignancy occurs in earlier age, so the tumors are very much aggressive, or there may be a history of familial history, so these tumors are very much aggressive, and the male are more affected than the females. There are several predisposing factors. Mostly it is related to the diet and the environmental factors. The diet, which is low fiber containing, or the smoked fish and high content of refined carbohydrate in diet, red meat, and less intake of micronutrients, especially the selenium deficiency. The tumor mostly arises from the colonic epithelium. Mostly they are the adenocarcinomas, and macroscopically the tumor may take one of four forms. These are the annular, second is the tubular variety, and the third ulcer, and the fourth one is the cauliflower type. Annular type and the tubular form, mostly they present as obstructive symptoms, but the ulcer and ulcerative and cauliflower types, mostly they present as bleeding per rectum. The tumor spreads locally, and second is the lymphatic spread. The lymph nodes are mostly affected by in the course of the primary vessels, and third one is the hematogenous spread. There are several staging systems for the colonic carcinomas. One and primary is the Dukes. The second one, which is most commonly nowadays used, is in the worldwide, is the TNM classification. So the Dukes staging is basically A, B, C, and D. A is not breaching the muscularis propria, and B is breaching muscularis propria and not involving the surrounding structures. C is involving the lymph nodes, and D with distant metastasis. So A Dukes having 5-year survival is 90%, B having 65%, and C is 35%. The TNM is basically nowadays practiced universally. The T is tumor, N is lymph nodes, and the M is distant metastasis. By combining all these three, we stage A, B, and C, and D. T0 is no evidence of the tumor. The tumor in situ when limited to the mucosa, and T1 invasion of the lamina propria or submucosa. T2 is invasion of the muscularis propria, and T3 is invasion through muscularis propria into the subserosa or non-peritonealized perimuscular tissue, and T4 is the invasion of the other organs or structures. And lymph nodes, 0 means none, no evidence, and 1 is when 1 and 3 positive pericolic lymph nodes are present, and N2 is 4 or more positive pericolic lymph nodes, and N3 is any positive node along the named blood vessels, and M0 means there is no distant metastasis, and M1 is the distant metastasis. So the common sites for the metastasis are the liver, lungs, and bones, and other sites, serosal sites, membrane of the peritoneum cavity, can involve like the retroperitoneal structures like the kidneys, the ureters, and the other structures, pancreas. So the survival of the in TNM staging, in stage 1 92% 5-year survival rate, and 2 is 87, and 2B is 63%, and 3B is 69%, and 3C is 53%, and 4 is 11%. So the signs and symptoms of the left-sided colon are mostly they present with pain, altered bowel habits, and the palpable lump and abdominal distension. And in sigmoid colon and the rectum, there is a pain in the lower abdomen, and there is a tenesmus, and if there is involvement of the bladder, so the patient may present with bladder symptoms like urinary urgency, difficulty in urination. So the transverse colon carcinomas mostly present with palpable lump, anemia, and weakness. Carcinoma of the cecum and ascending colon present as anemia, lump in the right leg fossa, or acute appendicitis or intermittent obstruction. If there is a distant metastasis, the liver may be palpable, or patient may present with jaundice or abdominal distension like there is ascites. After doing clinical examination, history and clinical examination, there are investigations. So digital rectal examination is the mandatory examination. By doing DRE, we can diagnose the rectal tumors which are 7 to 8 centimeter from the anal verge, and the fecal testing for the occult blood loss, barium enema, sigmoidoscopy, colonoscopy, and by doing sigmoido and colonoscopy we can take the biopsy to confirm the diagnosis. So for the staging purpose, CT scan of the chest, abdomen, and pelvis are done routinely, and serum tumor markers are the CEA level which is raised in the colonic carcinomas, and molecular detection of the APC gene, because there is changing mutations in the APC gene. If there is a 53 gene is present, and it indicates that there is a invasion, more invasion if the P53 gene is present. So for the diagnosis of the colorectal carcinomas, we have to do the sigmoidoscopy and colonoscopy with tissue biopsy. We can do double contrast barium enema, in which we pass barium as well as air per rectally, and we take serial X-rays to diagnose the colonic carcinomas or polyps. If there is a colonic carcinoma, the diagnostic sign on barium enema is apple core appearance or the filling defect. Ultrasound is mostly done for the liver metastasis, and the CT scan is done for the staging purpose, CT chest, abdomen, and pelvis. But the MRI is done in mostly if the tumor is in the rectum or lower rectum, to diagnose the perirectal penetration. So the main treatment that can be used for the colon and rectal cancers is the surgery, and the other treatment options are radiotherapy, chemotherapy. Depending on the stage, we can aid the surgery along with radiotherapy and chemotherapy, which is called the adjuvant and neoadjuvant chemoradiotherapy. Surgery is often the main treatment for earlier stage colonic cancer. if there are polyps present, which are smaller polyps, which can do the polypectomy with snare with the colon with the help of the colonoscope. And if the tumor is present in the colon, we had to resect according to the location. So if the tumor is present in the cecum and the ascending colon, we had to do the right hemicolectomy. And if the tumor is present in the transverse colon, we have to excise the transverse colon, or we can do the extended right hemicolectomy. And if the tumor is present in the splenic flexure or in the left colon, we have to do the left colectomy. So the preoperative preparation is, if the patient present with anemia, we have to transfuse the blood, and if the patient is severely malnourished, we have to correct the nutritionally imbalance, and we had to correct the electrolyte imbalance. If the patient present in emergency in intestinal obstruction and perforation, we had to perform the exploratory laparotomy and deal according to that. But if the patient present in emergency, the morbidity and mortality are more as compared to elective operations. The bowel preparation is not done nowadays, but if the tumor is in the rectum or in the sigmoid colon, we have to prepare by giving laxatives and enemas and prophylactic antibiotics, because to reduce the risk of infection. And when the laparotomy is done, the tumor is assessed for the irresectability by checking the involvement on the liver, the peritoneum, the lymph nodes, and the tumor for its mobility. In case of operable cases, the right hemicolectomy is done for the cecum and the ascending colon, and for the hepatic flexure, the extended right hemicolectomy. And carcinoma of the transverse colon, we have to do the extended right hemicolectomy, or we have to excise the transverse colon, and we have to anastomose end-to-end anastomose. Carcinoma of the splenic flexure and the descending colon are mostly done by doing the left hemicolectomy. This is the diagrammatic presentation in which this is the cecum and the ascending colon. This is a line mark which is showing the right hemicolectomy, limited right hemicolectomy, and in extended in the right hemicolectomy, we had to excise the cecum, the terminal 20 centimeter of the terminal ileum, and the transverse and part of the transverse colon by ligating the ileocolic vessel and the right colic and the right branch of the middle colic artery. In transverse colectomy, we had to ligate the middle colic artery, which having two branches, the right as well as on the left branch of the middle colic artery. If we ligate these, so the vascularity will be finished, or by ligating the middle colic vessel. This is the tumor at the splenic flexure. So we have to perform the left hemicolectomy. This is the tumor at the descending colon, and this is the line which is showing the resection line, and this is the sigmoid colon. By ligating the vessel to the sigmoid colon, we can resect these, and we have to anastomose the ileum with the colon or colocolic anastomosis, depending on the location of the tumor. In case of inoperable cases, there is a procedure which is called the palliative procedure. If the tumor is in the transverse colon and which is inoperable, we have to perform the transverse colostomy. And if the tumor is in the pelvis or in the rectum, so inoperable tumor, so we have to perform the sigmoid colostomy. Or if the tumor is in the ascending colon, so we can bypass by doing the ileocolic anastomosis. Thank you. If you have any queries, you can ask in the next lecture.